Okay, so now we have a little idea where the group stands on some of these issues. So now we'll get into the real reason why you're here. And I have the honor of introducing our keynote speaker. And I want to get these slides. Oh, come on. Well, I'll do that in a minute. We have the pleasure of having Dr. Thaddeus Pope joining us. He is an associate professor of law and a member of the Health Law Institute at Widener University School of Law in Delaware. Prior to that, he's been in private practice and he's clerked on the U.S. Court of Appeals for the Seventh Circuit. He earned his bachelor's in philosophy from the University of Pittsburgh and his JD and PhD in philosophy and bioethics from Georgetown University. He's written numerous articles and given several presentations on the topic of medical futility. We're very pleased to have him. Please welcome Dr. Pope.
Thank you. Good morning.
Good morning.
You're all warmed up now. So as I'm a California licensed attorney, and I teach law in Philadelphia. So it's sort of odd, that I'm here in Wisconsin speaking to healthcare professionals. Right? It doesn't really seem to line up geographically or professionally. So I just want to quickly give you 3 points of connection. First, almost all of my family lives in Milwaukee, represented by the red dots on this map. Second, as you just heard, I clerked on the U.S. Court of Appeals for the Seventh Circuit, which is basically the form of last resort for all federal cases in Wisconsin, Illinois, and Indiana. And third, I was actually introduced to Meritor back a few years back when the Preston case was being litigated up and down through the courts of Wisconsin. Actually, I'm not going to talk about EMTALA today, which was the issue in that case, because EMTALA is largely, I think, irrelevant to these sorts of cases, because of the inpatient rule, right? Most of the patients in these cases are inpatients, and EMTALA just categorically doesn't apply to them. So what I want to do, and we're going to talk about the law, but before we get there, I want to give some groundwork. So I want to give you a definition of medical futility disputes, look at their causes, and then look at their typical resolution pathway. And I just might note here, just stop, take a second, that this is obviously a topic of significant interest. It's frequently on the agenda of national and regional professional medical associations. In fact, this locally today at the Wisconsin Surgical Society, and in just the past few weeks at the Children's Hospital of Wisconsin. So what is a medical futility dispute? Well, there's a great deal of discussion about futile treatment. Much of that has been documented by the Dartmouth Atlas and by other studies. The Congressional Budget Office has issued dire warnings, right, about how much waste, how much futile treatment there is. Action is needed to avoid the possibility of a serious economic disruption. But our target this morning is not the amount of non-beneficial treatment, but disputes over non-beneficial treatment. Many healthcare providers provide overly aggressive treatment at the end of life. They don't want to stop. And there are many causes for this. Their own anti-death attitude, maybe their own religion, reimbursement incentives, or just their sense of the goals and ends of medicine. And while all these factors are interdependent, I want to zoom in on just one factor for overly aggressive treatment, non-beneficial treatment, and that's surrogate demands. So futility dispute is where the patient herself, whether through an advance directive, through any type of surrogate decision maker, wants to continue treatment, usually life-sustaining treatment. But the healthcare provider wants to stop. And of course, things are actually often messier than this. There may not be uniformity among the treatment team. People within the treatment team, there may be disagreement. Within the family, there may be disagreement. But for the sake of manageability, I'm going to assume a unity on each side, on the side of the family, on the side of the healthcare providers. So this is a survey from the August 2008 Archives of Surgery Journal. Nearly 800 healthcare professionals were asked this question. Do patients have a right to demand care that doctors think will not help? 44% said yes. And many argue this number is way too high. But again, I don't want to focus on that. In terms of medical futility disputes, we should focus on this gap, on this difference between how the public answers this kind of question and how healthcare professionals answer this kind of question, because this is where the disputes come from. So again, 44% of professionals said patients had that right, but 72% of the public, right? So there's a 28% differential. Similar question, same survey. If doctors believe there is no hope of recovery, would you prefer comfort measures, or would you prefer all efforts to continue indefinitely? Almost no healthcare providers said yes to this, but 21% of the public did. So why do surrogates demand treatment that their providers deem non-beneficial? And so I, as we just did, have inserted a series of these polls in the middle of my presentation. So let's just stop, take a second, and see what you think are the reasons why surrogates demand. This is not exhaustive, but I tried to list some of the main ones. Prognostic distrust. I guess I didn't check to see how many numbers there are in the clickers. Maybe it doesn't go this side. But prognostic distrust, racial or ethnic reasons, religion, guilt or loyalty, family dynamics, financial or some other reason.
Do you see a polling bar at the top?
Yep, we're up to 100.
Oh, sweet. Okay, good.
Okay, slowing down. So, okay, so family dynamics, 34%, guilt, loyalty, 27%, prognostic distrust, 16%. And I can't quantify these, but I want to review these reasons before we get to the analysis of the disputes. So there's a great deal of prognostic distrust, mistrust, that surrogates distrust the prognostic estimates of their physicians. It's been documented again and again. And in fact, with patients feel more empowered to question their physicians, right? With greater access to medical information, they're more confident in opposing their healthcare providers. Racial distrust. There's a substantial body of evidence that shows that African Americans and Hispanics are more likely to request unconditional prolongation of life-sustaining treatment, less likely to accede to the recommendations to withdraw. There's economic distrust, right? And today, where the incentives created by managed care are well known, even non-minorities are distrustful, right? And perhaps there's no better illustration of this than the description of advanced care planning as death panels, or even sometimes as horse